Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Dr. Stephan Nicholls in Melbourne, Australia, in order to discuss the novel CETP inhibitor, Obicetrapib, as a potential old novel treatment strategy for primary and secondary prevention of atherosclerotic cardiovascular disease. Dear Steve, it's a pleasure to host you as our, I guess, second guest from Melbourne and fourth guest from Australia. Thanks so much for being with us.
Thank you.
Thanks also from my side to be with us. Just a brief introduction. Professor Nicholls, well known to everybody in lipidology, is a director of the Victorian Heart Institute in Melbourne, and he's also professor of cardiology in Adelaide, consultant cardiologist at the Royal Adelaide Hospital, and he's principal research fellow of the National Health and Medical Research Council of Australia. As I said, he's a world leader in clinical and academic lipidology, and he's been a PI of several landmark studies published, I think over 700 papers on that, and we're very delighted, Dr. Nicholls, to have you here to discuss the recent results.
Right, thank you very much, and it's a pleasure to be here. So at the AHA, at the end of last year, we presented the results of the Brooklyn study. Brooklyn is an important study of the CETP inhibitor obicetrapib, and it focused in patients with heterozygous familial hypercholesterolemia. And you know, as you've already heard, CETP inhibitors are not a new kind of notion, but how we're thinking about developing them clinically is a lot different than where we were 20 years ago, when we thought it was all about their ability to raise HDL cholesterol and whether they would be protective. Now, very much the focus is on their capacity to lower LDL cholesterol, and the genetics would suggest that not only can they lower LDL cholesterol, but it would be LDL cholesterol lowering that may result in lowering of cardiovascular risk. This slide summarizes my disclosures. So we know heterozygous FH is common. It's associated with an increased risk of premature cardiovascular disease. Many patients with heterozygous FH fail to achieve their LDL cholesterol targets despite use of existing lipid-lowering therapies. As I've already introduced, obicetrapib is a CETP inhibitor. And we know from early trials with this agent that we not only see a lowering of atherogenic lipid parameters such as LDL cholesterol, non-HDL cholesterol, ApoB, but also raising HDL cholesterol when added to statin therapy. The objective of the Brooklyn study was to evaluate the efficacy, safety, and tolerability of obicetrapib as an adjunct to maximally tolerated lipid-modifying therapies in patients with heterozygous FH and suboptimal LDL cholesterol control. Here's the study design. We enrolled 354 patients. They were at least 18 years of age. They had to have heterozygous FH, which could have been diagnosed by either genetic analysis or one of several clinical criteria. They needed to be receiving maximally tolerated lipid-lowering therapy and have an LDL cholesterol of at least 70 milligrams per deciliter and a triglyceride below 400 milligrams per deciliter. We randomized patients in a 2-to-1 fashion to receive 10 milligrams of obicetrapib or placebo daily for 12 months. The primary endpoint of the study was the percent change in LDL cholesterol from baseline at day 84, but we had an opportunity to look at a range of other efficacy and safety and tolerability parameters. Here are the demographics of patients in the study. Mean age was in the mid-50s. A little over 50% of patients were female. The vast majority of the patients in this study were white. About 1 in 5 patients had diabetes. More than 80% of patients in both groups were treated with a statin. Most of the statin was high intensity in nature. You can see about 50% of the patients were treated with ezetimibe, and about 1 in 5 patients were treated with a PCSK9 inhibitor. So in the context of a study of a new lipid-lowering agent in patients with FH, these were pretty well-treated patients, lots of high-intensity statins, a lot of ezetimibe, and an increasing use of PCSK9 inhibitors compared to what we might see in our daily routine clinical practice. In terms of baseline lipid parameters, the LDL cholesterol was about 120 milligrams per deciliter. You can see patients had an HDL cholesterol of about 50, and Lp(a) levels probably about 40 nanomoles per litre. As you'd expect for a cohort where we're not recruiting patients specifically on the basis of having a high Lp(a). Here is the primary endpoint of the study, the percent change in LDL cholesterol over the course of the study, and we saw placebo-adjusted reductions in LDL cholesterol with obicetrapib by 36.3% at day 84 and by 41.5% at day 365. This slide shows the waterfall plots showing individual percent changes in LDL cholesterol in both treatment groups. On the left, 3% of patients treated with placebo achieved more than 50% of LDL cholesterol, lowering of LDL cholesterol. On the right, 34% of patients treated with obicetrapib. So at least one in 3 patients achieved at least 50% lowering of LDL cholesterol. If we look at percentage of patients achieving different LDL cholesterol targets, 24% of patients got an LDL cholesterol less than 55 milligrams per deciliter. 51% of patients got their LDL cholesterol less than 70 milligrams per deciliter. And 77%, or more than 3 in 4 patients treated with obicetrapib, got their LDL cholesterol less than 100 milligrams per deciliter. If we look at other changes in other lipid and lipoprotein parameters, we saw reductions in non-HDL cholesterol by up to 37.5%, reductions in ApoB by up to 25.8%. We saw robust increases in HDL cholesterol, which you'd expect with a CETP inhibitor, by up to 138.7%. Modest, albeit significant, reductions in triglycerides by up to 11.7%. For the first time, we were able to look at NMR analysis of lipoprotein particles, and we saw significant reductions in both the total number of LDL particles and in particular, a really robust reduction in small LDL particles in the circulation. We saw no significant increase in levels of hsCRP. That was an important finding given what we'd learned from some of the prior CETP inhibitors. When we looked at changes in Lp(a), again, baseline Lp(a) was about 40 nanomoles per litre. We saw placebo-adjusted percent reductions in Lp(a) by up to 54.3%. You can see again in the obicetrapib group with the waterfall plots on the right, 38% of patients achieved at least a 50% lowering, acknowledging that they started at pretty low levels at baseline. In terms of safety and tolerability, we saw reassuring findings. We saw no differences between the groups in terms of adverse events, their severity, or their relation to study drug. We saw no excess in terms of adverse events leading to drug discontinuation or death in the obicetrapib group. So overall, very reassuring. There were a number of events of special interest that we looked at. We saw no concerning signals if we looked at liver enzymes, muscle enzymes, worsening of glycemic control or new diabetes, worsening of renal function, all really quite favorable in terms of the safety and tolerability characterization in the obicetrapib group. We saw no episodes of macular degeneration over the 12 months of treatment. And while these studies were small, it's not power to look at events. Numerically, there were less cardiovascular events in the obicetrapib group compared to placebo. We'd seen with the first CETP inhibitor to go into clinical trials, torcetrapib, an adverse effect on blood pressure. This has been a parameter of interest for all CETP inhibitors that have subsequently been developed. We saw no increase in either systolic or diastolic blood pressure with obicetrapib over the course of the trial. There are limitations to all clinical trials. Firstly, the study evaluated the effect of obicetrapib for 365 days. The effect of longer treatment requires further evaluation. While we had good diversity in terms of gender, we didn't have great diversity in terms of race or ethnicity. So I think certainly points to needing characterization in broader cohorts. The Lp(a) lowering was observed in a cohort who were not required to have elevated levels at study entry. Additional studies will evaluate the impact of this agent in individuals with high Lp(a) levels. Those studies are underway. And whether treatment with obicetrapib results in a reduction in cardiovascular events remains to be determined. So in summary, obicetrapib reduced placebo-adjusted LDL cholesterol levels 36.3% at day 84 and 41.5% at day 365. with more than 50% reductions observed in 34% of patients. Obicetrapib resulted in placebo-adjusted reductions in Lp(a) by more than 54%, and that was independent of lowering of atherogenic lipid parameters and raising HDL cholesterol levels. Obicetrapib was well tolerated with no safety concerns. It's important to note that the longer-term effect of obicetrapib on cardiovascular outcomes is currently being evaluated in a large trial called PREVAIL, which we are leading and is ongoing. The findings suggest that obicetrapib has considerable promise as an approach to more effective lipid control in high cardiovascular risk patients, such as those with heterozygous FH. And thank you for your attention on that. Happy to take any questions.
Yeah, thank you, Steve, for that great data. Great to hear that. And I remember you mentioned Illuminate, and remembering 20 years ago when I was a young resident, I had to recruit patients for Illuminate. And that was the first trial I recruited patients for. And we all were really astonished hearing the data. I think it was during AHA years ago. Could you, to our viewers, just explain what is the promise, or what's the difference between obicetrapib and those older CETP inhibitors?
Well, I think we learned a lot, and you know, clinical trials, you know, we talk about whether they're negative or positive. I don't think there's such a thing as a negative clinical trial. I think they all have an opportunity to inform, and we need to learn from them. And we learned a lot from the early clinical trials of CETP inhibitors. The first agent, torcetrapib, was in the Illuminate study. Not only did it not reduce cardiovascular risk, in fact, it increased cardiovascular risk. It increased cardiovascular events, increased both cardiovascular and non-cardiovascular mortality. And we learned that it had pleiotropic off-target effects, and it had a number of toxicities, effects on the adrenal gland, endothelin, blood pressure, a number of other factors. And what that taught us was that, and we didn't think that had anything to do with CETP. So it taught us that if there were other CETP inhibitors that lacked that toxicity, they were worth pursuing. So we tried to do that. The second agent was an agent called dalcetrapib. Dalcetrapib is pretty modest CETP inhibitor, raises HDL, doesn't lower LDL at all. And we stopped that clinical outcome trial because it was futile. The third agent, an agent called evacetrapib, much more potent, raised HDL, lowered LDL, probably not as much as we thought in early trials, and certainly didn't lower ApoB as much as we thought. And we probably did too small a study and didn't treat patients for long enough. It didn't work. The fourth study, a study called REVEAL of an agent called anacetrapib, a potent CETP inhibitor with lipid effects that are not dissimilar to what we see with this agent, was a much larger study. Patients were followed for 4 years. We did see a significant reduction in events. It did look like the reduction in risk was associated with lowering of LDL and not raising HDL. And in fact, subsequently, we've looked at genetic studies that have really confirmed the same. So if you look at all of those examples and you say, well, what did we learn from each of them? We learned develop a drug because it's good at lowering LDL, develop a drug that doesn't have torcetrapib type toxicity, and then design trials where you think an LDL lowering drug would be useful, i.e. patients with high LDLs. And so we think that that's been important in the way that we've designed the Brooklyn study in FH, the Broadway study, which is a much larger lipid study in high CV risk patients with or without FH. And PREVAIL is essentially high CV risk and high LDL looking at events. So again, we won't know until we see the results of that trial in a few years' time. But I think that it really is a nice example of where we've learned from the trials in the past that have continued to help to inform whether we're ultimately right or wrong. The clinical trial will tell us.
But you would consider obicetrapib just much more potent than the other agents and not having the side effect, because the dosage is lower actually as for, I guess, all the 4 previous agents you mentioned.
It absolutely is. And so while it produces similar type of lipid effects to what we said with anicetrapib. It does it with a much smaller amount of mass of drug, so much more potent. We learned with anicetrapib that it had some adipose tissue accumulation issues, and that's part of the reason why an agent that reduced cardiovascular risk in an outcome trial didn't come to the clinic. Again, we've learned a lot about the pharmacology here that helps us design the drug, design the trials. Hopefully, it helps us inform how we should be treating our patients.
The study is great. I mean, the Brooklyn data you just show patient population is young and then 50% female, just as you'd expect in heterozygous FH. You already alluded to the Broadway trial. We've just seen a press note out a few weeks ago from the producer, basically showing similar result that what you just presented. Is that right?
Yeah, so I think what's in the public domain is Broadway, which is a study of about 2,500 patients, high CV risk. So that was ASCVD or FH. Again, had to be treated with good lipid-lowering therapy and have an LDL cholesterol that was high. We're seeing placebo-adjusted LDL cholesterol lowering that's similar to what we saw in Brooklyn. So we get to hopefully share that with the scientific community soon in much more detail, but all of those things are lining up. And what's really important has been that in both of these studies, and in fact the earlier studies that were done with this agent, the safety and tolerability looks really good. So we feel there's a clean drug. We feel that we're seeing pretty consistent effects on lipids and lipoproteins. The question will be, will that translate to a reduction in cardiovascular risk? Prevail's got 9,000 patients, which are fully enrolled, and we just have to wait and see.
Well, if it's all LDL cholesterol, and you mentioned that also in contrast to the other CETP inhibitors, that we see the strongest risk reduction in LDL from everything we know, statins, ezetimibe, bempedoic acid, PCSK9 inhibitors, whatever we do, also the genetics. If you lower LDL, you'll eventually lower events. So that cannot go wrong, actually, one would assume. The question would be, and we discussed that here, with other people, and you, I think, are also involved in other trials where we see different approaches in lipidology, angiopoietin 3 inhibition or ApoC3 inhibition, sorry, and angiopoietin also, where you have a different sort of approach or target. If it's all LDL with obicetrapib, where's the I mean, do you have a signal from the studies and the data you have? Is there a difference in the LDL cholesterol that has already been lowered? So would it also still work in patients on PCSK9 inhibitor, on statin, on ezetimibe, or will it eventually lower off sort of?
Well, this was a study that was conducted in a lot of people on statins, half the people on ezetimibe, and 1 in 5 patients on a PCSK9 inhibitor. So it was pretty good background therapy, and we saw additional lowering. I think that's important. You used to really, I smirked as you said it. The key word in your opening statement was the word eventually, and I think that's one of the traps that we've had in some of the clinical trials where the LDL story has not necessarily held up as much as we thought it might, because we haven't treated patients long enough, and that's one thing that we've learned in large CVOTs in the lipid space. You have to be patient. You have to accept the fact that it's going to take 6-9 months before the curves start to separate. We think one of the reasons why we didn't see any benefit with obicetrapib was we simply didn't treat the patients long enough. So that's been embedded into this program. It's embedded into a range of others. We probably have to make similar types of assumptions as we start to develop some of these other therapies that target triglyceride-rich lipoproteins, lipoprotein little a. We're going to have to be patient and design long trials, because I think until we see a benefit, we just won't know how long it will take to accrue those benefits. And what we don't want to do is do trials that are just simply too short and abandon not only potentially promising therapeutics, but classes of therapeutics. And if this agent comes to the clinic, it is going to reflect an enormous amount of patients by a lot of people, developers, trialists, investigators at sites, importantly patients, to think that they stuck with 5 CETP inhibitors to get one to the clinic it would be an extraordinary testimony to patients.
Just a simple, maybe too simple question, but the thing is, what is remarkable is that this substance lowers LDL ApoB, Lp(a), triglycerides, and is that different from the older substances, or is that a new finding? And of course, the question, how is that possible? What we learned years ago is, well, there's HDL, and it takes some particles from the LDL, and when we have more HDL, and nowadays we have such a broad spectrum of effects on every parameter. And how does that come?
Well, I think the phenomenon with these agents is not new. I think the magnitude of the effect kind of going along with the potency probably brings it far more into focus. So, you've got an agent that lowers LDL, so therefore lowering ApoB and non-HDL cholesterol is probably not that surprising. The Lp(a), if that translates to patients with high Lpa levels, that's going to be pretty important all in its own right. I think we've learned a lot about CETP and its role in lipid metabolism, CETP inhibition and its impacts on lipid metabolism, but there's still probably a lot to still learn. We think it's clearly more than just simply inhibiting that flux of cholesterol between lipoprotein particles, and that it's likely to have a flow-on effect on LDL receptor expression and throughput through the system, and that's where lipid kinetic studies become important, and people who are really good at that have demonstrated that there are effects there on other parts of lipoprotein metabolism, and that may start to then contribute to the totality of lipid benefits that you see with an agent like this. But if it, as to how many of those individual effects contribute to benefit, well, let's see if there's a cardiovascular benefit, and then we can start to do more analysis to try and understand what really kind of was underlying that.
It's really great to have all these new treatment classes on the horizon, at least, and we're so thankful to you for doing all these endpoint studies. But surely we love to speculate a little bit. And do you see maybe some patients that may benefit more from CETP inhibitors and others that may benefit more from ApoC or even NGPTL3 inhibitors? And again, you do all these trials, or should we just wait to see the data and stop speculating on that?
I think speculation's fantastic. I do it every day. Wouldn't it be wonderful if in the end of the day, all of these agents worked? It's wonderful for us. It's actually great for our patients, but then the question's going to be how we're going to make decisions, because we can't use all of these agents for every patient. They're expensive, and if you add all of them up, there will be a considerable expense. But also, we want to think about what will work for patients. Are there biomarkers that might triage a patient? So the patient who's got a high triglyceride level, maybe I am inclined to want to think about an ApoC3 or an ANGPTL3 inhibitor. If it's pure LDL, maybe I want to think about a PCSK9 inhibitor, CETP inhibitor. If the patient doesn't want to take an injectable, then they might be more inclined to want to take a CETP inhibitor or an oral PCSK9 inhibitor, and those agents are currently being evaluated in clinical trials. And so, when we've talked about this notion for many years about can we personalize therapy, and we may be in the not too distant future be able to do that with some fairly simple kind of characteristics, and then maybe AI helps us kind of be more focused, be above and beyond that. I think it would be a really good outcome for patients that they would have choice about how to lower their cardiovascular risk.
And I would love to add 2 final questions from my part, at least. So how comes that the phase 3 studies with all these novel agents go just with one dosage? We have the statins, which we use to titrate according to LDL levels, and everything came actually after the statins, ezetimibe and whatsoever, just comes with one dosage. Is it just because it's easier for the companies to sell the message, or would you really see this as kind of a switch on and off, so that we need just this one dosage? My last question then would be, in your waterfall plots, you had some very few people who had actually a large increase in LDL cholesterol. Were these people who just didn't take their pills?
Well, maybe start with the last question, maybe a little bit of that. Maybe they were at the lower end. We know there's variability in LDL cholesterol. It's why you have to, even with lipid studies, do several hundred patients. I think what determines what we take forward to an outcome trial, one, depends on the pharmacology. So you've got agents like ezetimibe, where there was really no real convincing evidence that a lower or higher dose was really going to do anything more substantially different. And we've already kind of touched on Obicetrapib actually being a pretty small amount of drug. So it's not like we needed to use less drug to it wasn't going to cost less to have 5 milligrams. So I think that's one element. Two, cardiovascular outcome trials are hard work. They involve enrolling a lot of people and following them for a lot of time. You want to have a second active dosing group, well, then you need to do a bigger trial. This is, by current standards, a modest size study, 9,000 patients. We've seen 13,000 was 14,000 was the bempedoic acid study, for example, that you referred to earlier on. You want to add on another group, that's several thousand more patients, and so that has implications in terms of the resources that it will take to actually evaluate a drug and then ultimately bring it to the clinic. And those of us who are kind of active in this field, we like the trials. What we're trying to do here is we're trying to change the way we practice, or ask the question, should we be changing the way we practice? And so the trials have got to end at some point in time to be able to get the answer to change the practice. So I think there's a whole range of factors that then go into how we do that. I would love multiple doses of agents, but it's often very difficult to do that in outcome trial setting.
One final question I have goes a little more into the details of the study. You presented the data on the LDL particles. I'm not sure if I understand that correctly. Could you explain that to our viewers also? What's the meaning of not lowering only LDL concentration, but the particles according to their size and the number of particles?
Well, we see that there's a reduction in LDL cholesterol. We would have expected that. We've seen it. We see a reduction in ApoB, and that's actually the first suggestion that we're not just reducing the content in the LDL fraction of the plasma, but you're potentially reducing the number of circulating atherogenic particles, such as LDL particles. And in fact, the NMR analysis is important because the first time that we've really had a proper look with that approach, looking at Obicetrapib, and you see the total LDL particle pool go down, and importantly, the small LDL particle pool go really a long way down. And it's important because it's, in the end of the day, it's those particles get in the artery wall. It's those particles that drive the inflammation and oxidation that really sets off and continues to promote atherosclerosis. So we continue to learn a lot about inhibiting this factor, the totality of lipid and lipoprotein effects. There is a study that's ongoing to recruit, looking at the effects on atheroma using CT coronary angiography. All of these will continue to tell us more and more. And as I said, after the results of all of those, won't it be interesting to go back and try and understand, was there a relationship between LDL particle lowering and slowing disease progression or reducing cardiovascular risk, or is it LDL cholesterol? I think there'll be many questions still to come.
Well, I think we all have a large number of more questions, but I think we learned so much already from you. Thank you so much, Dr. Nicholls, for your time. With all these studies you've been doing, we're so grateful for the data you present to the community. We realized that you are not only into the lipidology field, but also I think one of the first authors of the upcoming data on tirzepatide and cardiovascular outcome. So we're really all looking forward to that. That's also a field that's moving cardiology at the moment. And we're very eager to see the PREVAIL data once they come up and see how obicetrapib is going further. So from our side, thank you for your time, this short Q&A sessions, and thank you very much.
Thank you.